Hi, and thank you for joining our educational webinar with Dr. Stephen Sharp, who will discuss the importance of early screenings for colon and rectal conditions and the latest treatment options available. I'm Leslie Hartz, and I'm a member of the VCU Health marketing team. Before we begin, I would like to first make note that we will hold all questions until the end of the presentation. Please drop any questions you may have in the Facebook comment section throughout the event, and we will get to them during the Q&A portion. So let me tell you a little more about our speaker this evening. Dr. Sharp joined VCU Health in 2020 as a colon and rectal surgeon and assistant clinical professor. He has a particular interest in minimally invasive colorectal surgery, colorectal and anal cancer, surgical management of inflammatory bowel disease, diverticular diseases, benign anal and rectal conditions, and colonoscopies. His research interests include surgical outcomes, research for benign and malignant colorectal conditions, as well as colorectal racial disparities. Thank you, Dr. Sharp, for joining us today. I will now turn the show over to you.
Thank you so much, Leslie. All right, well, thank you everyone for joining us this evening. And again, my name is Dr. Stephen Sharp, and I'm Assistant Clinical Professor, Colon and Rectal Surgery here at VCU. I started in 2020, and today we're going to talk about some of the different procedures and conditions that we treat as colorectal surgeons here at VCU, and I'm going to be speaking in detail about one of those conditions, namely diverticular disease. So to give you a broad overview about what we treat here at VCU in our division of colon and rectal surgery, we perform colonoscopies, both for screening purposes as well as for patients who have a history of polyps or a family history of colon rectal cancer, as well as for patients with inflammatory bowel disease. We perform a variety of minimally invasive surgical procedures, both laparoscopic and robotic, for conditions such as diverticulitis, Crohn's disease, and ulcerative colitis, as well as colon cancer and rectal cancer. We also specialize in performing sphincter preserving surgery for rectal cancer, and we work collaboratively with medical oncology and radiation oncology in the complex treatment of colorectal cancer. We also treat a variety of benign conditions such as constipation, rectal prolapse, as well as surgical and office-based therapies for hemorrhoidal disease. We also perform other procedures such as colostomy, ileostomy surgeries, as well as reversing these stomas as well. Finally, we also see patients and help treat for anal cancer. So next, I'm going to go into what is diverticular disease specifically. So diverticulosis are small outpouchings or pockets from the colon, which are usually found on the left side of the colon and in the sigmoid colon. These can be very common. Some people may not even know that they have them, and they become a problem when they become inflamed or rupture, and that's known as diverticulitis. So the exact etiology of what causes this is unknown. It used to be thought that seeds and nuts led to them getting trapped in these diverticula, and that's what caused the inflammation and the rupture. But we now know that that is not the case any longer. The possibilities include a low fiber diet and increased pressure in the colon, as well as constipation. So patients who are at risk for diverticular disease are those who are over the age of 40. For some reason, it is more common in males. A low fiber diet predisposes to it, obesity or being overweight, and a diet that is high in processed foods and also a lack of exercise are predisposing factors. So the symptoms of diverticulitis would be persisting abdominal pain or tenderness, fevers and chills, abdominal cramping or bloating, and nausea or vomiting. So these are very non-specific symptoms, and these would be reasons why someone would want to see either their primary care physician, or if they're having very high fevers and other severe symptoms, such as severe chills, high heart rate, those patients may want to go to the emergency room. In that case, it may be a more severe attack. How is diverticulitis diagnosed? So we first start with clinical history and physical exam of the patient. Also draw some blood tests, looking at the white blood cell count, which is often elevated, and then performing a CAT scan and occasionally X-ray rectal enema study. Diverticulitis has different degrees of severity, and this is based on a classification system that, as physicians, we refer to as the Hinchey classification. And so Hinchey stage 1 is where there's a very small abscess around the colon here. So if you can see my cursor in the colon here, these are little diverticula, these little outpouchings here. And then where one of these ruptures is what leads to the severe infection. If the abscess cavity becomes much larger and extends to the pelvis, this is stage 2 disease. Stage 3 is where there is an actual rupture of that infected diverticulum, and so there may be fluid that leaks out into the abdomen. And stage 4 is where there's actual leakage of stool into the abdomen, that the perforation is not able to be sealed by the body. And so stage 3 and stage 4 typically indicate that's a more severe infection, and oftentimes those patients are needing to go to the operating room for a surgical procedure to intervene. So we initially treat diverticulitis with antibiotics, and that may either be oral antibiotics or through an IV with IV fluids and bowel rest, meaning nothing to eat or drink. If there is a localized abscess that is present around the colon and the infection has not spread, sometimes we have the radiology colleagues intervene to place a drain to drain the infection, which would come out at a later time. And finally, if the infection is severe enough, or if the number of attacks become much more frequent, then surgery may be recommended by your doctor at that point. So next I'm going to go into a little bit about the surgery and what to expect if it was recommended that you would undergo surgery for your diverticulitis. So oftentimes, if it's an elective surgery, we would perform a colonoscopy first to make sure that there are no underlying conditions leading to the infection, such as a malignancy or a cancer that's there. Oftentimes, patients will need to undergo a medical assessment to make sure that their bodies are at optimal conditioning for general anesthesia. Occasionally, we may have you meet with one of our enterostomal therapists. These are certified nurses who are used to working with ostomies, which are bags on the outside of the abdomen where the stool goes. And so they may mark the site, if you did need an ostomy, where that would go. And so they look and see where you wear your clothes, where your pants lie, where you have skin creases. And so that they really help to ensure that the placement of the stoma is in an optimal location so that you or your family can help manage that after the surgery. So there are a few different types of surgery that we perform for diverticulitis, and it depends on the severity of the disease, and it depends on how extensive the infection is, and it depends on if other organs are involved, or if there's other parts of the bowels that are involved with the diverticulitis as well. So in the more minor cases where surgery is recommended, we perform what's known as a primary connection, which is where the two ends of the colon are joined together. And there's a special stapling technique that we use that utilizes titanium staples, which are permanent, and that joins the two ends of the bowel together. Occasionally, if the infection is very, very severe and there is concern that the two ends of the colon may not heal properly together, we perform a temporary ostomy here on that you see here on the outside, which is called an ileostomy. And what that does is it allows the two ends of the colon, which have been joined together, time to heal, and then we would perform a couple of tests later on, a couple of months after the surgery, to verify that those ends have healed, and then this ostomy would then be removed and the bowels would be put back together. And then finally, the diagram here on the bottom is what's called a Hartmann's procedure and a colostomy, which is colon here. And this type of procedure is performed in an emergency setting when the colon has ruptured and there is spillage of fecal material into the abdomen. And at this point, patients are typically very, very sick. Their blood pressure may be low. They may need to be on special intravenous fluids and medications to support their blood pressure. And at this point, the surgery that we perform is to prevent any more spillage of fecal material into the abdomen, and we do this colostomy on the outside, which can be reversed at a later date depending on medical conditions and the disease severity. Now, during the surgery, this is performed under general anesthesia, so patients are asleep the whole time. You won't feel anything as far as the incisions go, things like that. They can be done open, laparoscopic, or robotic. So here in this diagram, these two, this is a laparoscopic procedure, and then here on the lower right hand is a larger incision, which is an open procedure, which may be done in cases where there's extensive scarring or the infection is very, very severe. The surgery generally takes 2 to 6 hours, depending on the severity of the disease. And if a temporary stoma is required, that's usually left in place for approximately 3 to 6 months to allow the connection between the colon to fully heal. So after the surgery, you're in the hospital typically for 3 to 5 days afterwards. The nurses provide you with a special breathing device called an spirometer to assist with preventing pneumonias, and you're able to get up out of bed and walk, typically either later on that day or the following morning. We employ multimodality pain control here with a close collaboration with our anesthesia colleagues. We use a combination of non-narcotic medications such as Tylenol, Motrin, and Toradol, and we prefer to use non-narcotic IV pain medications, because these have been shown to really enhance the recovery of patients after surgery. If required, we will use narcotics, but these can tend to have a lot of adverse side effects, such as nausea and vomiting. They impede the return of bowel function after the surgery. So the latest research has shown that as much as possible, we try to avoid narcotics in patients after major surgery like this. We will accelerate the diet fairly quickly as long as patients aren't having any nausea or vomiting. And you'll often be prescribed shots in the subcutaneous tissues to help prevent blood clots. And typically 1 to 2 days after the surgery is performed, we'll remove the urinary catheter, and patients will be able to urinate on their own. Once you go home from the hospital, the physical activity restrictions are no heavy lifting, more than about 10 pounds for about a month. And we send you home with pain medications, usually a combination of non-narcotic pain medicine and a small amount of narcotics if needed. Diet is typically restricted to a low fiber diet initially for the first couple of weeks to allow that connection in the colon to fully heal. And then after about a month, then go back to full unrestricted diet. No driving or operating a vehicle while you're taking narcotics. And you'll typically follow up with your surgeon 2 to 4 weeks after surgery. And things to look for include fever greater than 101 degrees, elevated heart rate, dizziness, lightheadedness, nausea, vomiting, a decreased urine output, or feeling dehydrated. So this is an overview on the medical and surgical treatment of diverticular disease. And as I said before, as colorectal surgery here at VCU, we perform a very wide range of procedures. We see a lot of different types of patients with very, very different types of conditions of their colon, their rectum, their small intestines. And so we have a lot of resources at our disposal to try to help patients to improve their quality of life with a lot of these debilitating conditions. We find that oftentimes patients are embarrassed or scared to talk to their primary care physician about things like hemorrhoids or bleeding. And this is something that we want to try to promote to get more people to be seen, because there's a big push to really get these conditions diagnosed and treated early. Especially nowadays, we're seeing a significantly elevated rate of colorectal cancer in younger patients. And so we've seen patients very, very young in their early 20s who have presented with rectal bleeding and change in bowel habits. And so this is something that we are very passionate about, and that we want to try to engage with the community to enhance patient knowledge and know when there's something that's abnormal, that we want you to talk with either your primary care doctor about it, or to call our office directly to be scheduled with one of our providers. There's 4 of us in the practice here, and we would be more than happy to see you for these things. And now we will take questions.
Thank you for the informative presentation, Dr. Sharp. We will now open the floor to any questions. Before I address these, We'd like to first read a few that were submitted in advance. What gastrointestinal symptoms signal an emergency?
So typically, severe abdominal pain that is unrelenting and that does not go away within a matter of 3 to 4 hours. And that may be associated with nausea or vomiting. And it may also be accompanied by a very high heart rate, over 100 beats per minute, and also feeling very clammy, chills, as I said, fever. Those are things in that scenario that it would be recommended that that you go to the emergency room in that case.
Okay. Can increasing fiber assist with improving symptoms associated with colon and rectal conditions?
Yes, absolutely. A lot of conditions that we see, benign conditions like hemorrhoids, diverticular disease, a lot of this can be treated by increasing fiber in the diet. So raw fruits and vegetables are very good. One of the things that I will say is that oftentimes it is very difficult to have enough fiber intake. So even though we always think that we're taking in a lot of fiber, we eat a lot of raw fruits and vegetables, it actually is very, very hard to get in the recommended daily intake of fiber. And so very oftentimes we will recommend an over-the-counter fiber supplement such as Metamucil or Consul, Citracel. Those can all be purchased over the counter at grocery store, CVS, Walgreens, drugstores, and so those actually will provide a lot of symptom relief for a lot of the benign conditions that we see.
Okay, thank you. We've heard IBS or irritable bowel symptoms can be confused with more serious conditions like Crohn's disease or colon cancer. What are the differences in symptoms?
So a very good question. Oftentimes there is a significant overlap in the symptoms of irritable bowel syndrome and things like Crohn's disease, ulcerative colitis, and colon cancer. So that's why it's important to speak with your healthcare provider regarding these symptoms so that you can be appropriately screened and to be evaluated for these more serious conditions. So typically in those cases, things like colonoscopy would be performed with biopsies to look for any signs of underlying malignancy or inflammation, which we may not see with irritable bowel syndrome, but it can be difficult to distinguish between these multiple disease states just by history alone.
Makes sense. What are the differences between colon cancer and rectal cancer?
So colon cancer and rectal cancer, they have very similar etiologies. So colon cancer can be in the right colon, the transverse colon, or the left, the descending colon. And so the rectum is approximately the final 12 to 15 centimeters of the distal end of the large intestinal tract. So they overlap as far as what the etiology and the causes are, but they do have differences in terms of what type of surgery may be performed and whether or not the need for chemotherapy or radiation may be required before or after the surgery.
Okay. Can colorectal cancer be prevented?
So very good question. So In a way, yes, and in a way, no. So the ways that it can be prevented are by healthy lifestyle, such as exercising frequently, eating a balanced diet, foods that are high in fiber, low in processed foods, and low in red meat. So there are conditions where colorectal cancer can be inherited. And so oftentimes, even with sporadic cases, there can be, it's often something that's in the underlying genes that we have. And so some people, even though they're very healthy, they live a healthy lifestyle, that they are still predisposed to cancer. And so the best way to treat it is early detection. And so that's why we recommend that anyone who's at the age of 45 who has no elevated risk of colon cancer undergo screening colonoscopy. For patients who have either a family history of colon cancer or they have underlying conditions that predispose them to colon cancer, such as ulcerative colitis or Crohn's disease, the recommendation is for even earlier colonoscopy. But as a preventative strategy, colonoscopy does save lives because it diagnoses and is able to treat those cancers early.
So you might have answered my next question. We have this one coming in. Will colonoscopy show cancer? So you will be able to know if you have it, or you can diagnose it through that procedure.
Yes. So colonoscopy, depending on the size of the cancer, it is very, very sensitive at detecting the cancers. We're able to detect polyps down to a few millimeters, and those can be precursors to cancer, and those would be removed at the time of the colonoscopy to try to prevent the progression of those turning into cancer. And oftentimes then we'll recommend a slightly more aggressive schedule to have the next colonoscopy performed, just because we know that those patients are at increased risk of developing cancer in the future.
Thanks. Okay, I understand. We had another question come in. Will increasing fiber help if you already have loose stool-inducing medications?
It can. Most definitely. It depends on the patient. In some cases, in a lot of cases, it will make it better, because what fiber does, especially insoluble fiber, like the kind that you purchase over the counter, is it helps to regulate the water content of the stool. So even if the stools are very loose, what fiber tends to do is to bring the spectrum of those bowel movements back towards a more regular consistency. So oftentimes for patients with very loose bowel movements, fiber can absolutely improve their symptoms.
Okay. If you've experienced a prolapsed hemorrhoid in the past, but it still bleeds occasionally, how often should this be checked?
So it depends on the symptoms that you're having. So if it's been prolapsed in the past and it still bleeds, you definitely want to make sure to have it looked at least once to make sure that there isn't something more severe going on. And depending on your age and other medical conditions, it may be recommended that you have a colonoscopy performed as well, to make sure that there isn't another source of bleeding that's above the level of where the hemorrhoid is, that may not be able to be evaluated in the clinic. But as far as once that's been evaluated and it bleeds occasionally, it depends on the severity of the bleeding as far as how often it should be examined. If there's just some minor bleeding on the toilet paper after you wipe when having a bowel movement, that probably doesn't need to be evaluated as frequently as if it's more severe bleeding, if it's you notice bleeding in your undergarments or bleeding that squirts into the toilet bowl with bowel movements. That's something that would need to be evaluated sooner.
Okay. I think that was all of our questions. It was a pleasure having you join us for this discussion, Dr. Sharp. It's common for these conditions to go untreated because many are unfamiliar with the symptoms or feel too self-conscious to seek help. So we really appreciate you being here. This conversation will certainly help in preventing and treating these conditions with early detection and prompt medical care. For information about colon and rectal surgery at VCU Health, visit vcuhealth.org and follow at VCU Health on Facebook. For more information about colorectal cancer, visit Massey Cancer Center at masseycancercenter.org. Again, thank you, Dr. Sharp, for joining us today, and have a great night.
Thank you, Leslie.